So, good morning, everyone, and welcome to the session that we have this morning in two parts on the contributions of Asian universities to initially health policy and systems development, and then following that, a session on implementation science, which my colleague Malavika Sarkar will moderate. My name is Peter Berman. I am a professor. I've been at Harvard School of Public Health and at the University of British Columbia, and many years of experience working on health systems issues, especially in Asia, with long years of residence in Indonesia and in India. So it's my pleasure to host this session this morning. And I want to start by expressing my appreciation to our five panelists from Asian universities for their willingness to participate and also prompt joining of the session at various times at night in the Asian regions. We were able to schedule this session in the morning in the US so that it wasn't too unpleasant for our Asian participants to join us. Let me briefly introduce everyone on my panel. First, Dr. Eduardo Bonzon is the director of the health practice team under the Human and Social Development Sectors Group at the Asian Development Bank, and he has taught at the University of the Philippines, Manila College of Medicine, and Ateneo de Manila University Graduate School of Business, and is also currently affiliated with the CUGH School of Public Health at NUS Singapore. Dr. Carlo Panello is professor at the Department of Clinical Epidemiology, University of the Philippines College of Medicine, Manila. He's also an advisor to the Philippine Department of Health and the Philippine Health Insurance Corporation, and has led various foreign-assisted technical assistance projects. Dr. Keisha Prem is an assistant professor at the CUGH School of Public Health at the National University of Singapore, and also at the London School of Hygiene and Tropical Medicine. She has done work extensively on infectious disease modeling related to HPV and has provided technical assistance to Laos and Cambodia. Dr. Sunman Kwon is a professor, business economist, and former dean at the School of Public Health at Seoul National University, and previously led the health team at the ADB, and he maintains a number of current roles in regional organizations with WHO and others. And I recently re-met Sunman after many years in Ethiopia, where we were both working there to advise that country on its health financing policies. And Professor Laksono Trisnantoro is a professor of health policy and administration in the Faculty of Medicine, Gadjah Mada University in Yogyakarta, Indonesia, and he also directs the Universitas Gadjah Mada Center for Health Policy Research. So welcome, thank you to all our panelists. And let me just turn now to each of them individually for brief presentations on their experience, and then we can open it up for some conversation or discussion later on. And the key focus here is for us to try to get a better picture on how university professors work together with governments to address issues around building better health policies and health systems performance. Dodo, let me start with you, please. Go ahead.
Thanks, Peter. And I think I'm in a very interesting position because I've been moving in and out, and I've also, in a sense, also was in government when I was running the Philippine Health Insurance Corporation. And at the end, whether now we're in ADB, where I'm supporting and advising countries implement reforms, UHC, university professors, in the way we look at it, and I'm quite lucky that we have it here. The one is that they generate knowledge and information, but the problem with that is that sometimes it doesn't translate really to what countries wants. So you have that first set, and we still, even within ADB, we still use a lot of outputs from universities on that. But what we're lucky is within this panel is you have university professors who are actually doing a lot of implementation support. In particularly, what we now have in Asia are countries with, let's call it, mature health reform processes. Asia, a lot of countries in Asia that we support no longer really needs to know what needs to be done. It's, it's been much discussed. But the challenge is really how to make it happen, how to make the UHC that Indonesia, Philippines, Cambodia has adopted and make it happen. And this is where we're now seeing the value of university professor helping translate this policies that's been adopted by country and make it happen on the ground. And Carlo, Laksono, and Sunman and Kesha can probably share more on that. I'll stop there, Peter.
Okay, thank you very much, Dodo. And you have given us a little bit of time space, so we appreciate that. Thanks very much. Sunman, let's turn it over to you.
Well, from a personal experience perspective, I got the leave of absence from my universities twice. So one time I worked in ADB, and on a second leave of absence to serve the government agency. And also my university is a public university, so we have some kind of a tradition that our faculty members in my university has participated in various government committees. So in that sense, we contributed first that the national health insurance system, universal health coverage within Korea, and also in other capacity, we also work with the Korean development agencies like the KOICA, Korea International Cooperation Agency. And also we have another health specific ODA agency called COFI, Korea Foundation for International Health. So we collaborate with them for various like Korean programs for helping many LMICs around the countries. But there are also, I think, in retrospect, there are some pros and cons. Like, it's a good that we can, as a faculty members, we can apply the theory or knowledge or research in the government real policy. So it's positive, and also, we also train, for example, those Ministry of Health officers or health insurance officers in Korea, and also the Ministry of Health officers from abroad. So in a sense, it's a good and like a potentially like a virtuous circle. But in retrospect, I've been a faculty member of my university for about 35 years now, and then some dilemmas sometimes as a reflection, such that sometimes as a researcher, if I become a part of this policy making and implementation, sometimes I feel a bit concerned and burdened whether I can still keep my critical view, right? Because if I'm a part of this policy making and implementation, sometimes I feel like I can lose my insight as a critical perspective. That might be a challenge. And also these days, this type of participating in both government policy as a serious researcher becomes more and more difficult, because these days the academic environment becomes too competitive in a sense. So for example, my junior faculty members, in a sense, I was lucky that I can do both. But for my junior faculty members, the pressure to be an academic excellency, in a sense, research excellency, or publish or perish environment becomes a more reality, more tougher and tougher. So I feel like a bit pity for my junior faculty members. So I was lucky because at my entire career, I was able to do some slack, in a sense, some a bit slack as in terms of research, such that I can apply to policy or really engage in policy. But that type of dual role seems tougher and tougher these days in the case of Korea. I'll stop here and I can contribute further later. Over. Thank you.
Okay, thank you, Sunman. And I do want to just for a moment, I was remiss in not expressing my appreciation to the Consortium of Universities for Global Health, CUGH, for helping us to organize and host this session. Dr. Keith Martin, the Executive Director of CUGH, is joining us on this call. And I would like to say that these two sessions are part of a wider effort of those of us at CUGH to strengthen contacts with universities in the Asia regions and discover ways that we can work better together and deliver value from CUGH to our colleagues in Asia, as well as deliver value from our colleagues in Asia to universities in the rest of the world. So thank you again for that. And then let me turn the floor over to Keisha next.
Hi, thank you so much. Are you able to see my screen right now?
Yes, we see it.
Perfect. Okay, I'm so sorry. I guess I believe that slides would help me guide the conversation. I don't have the confidence like Prof. Kwan and Dodo has. But anyway, I would just like to introduce Singapore's National School of Public Health and the work that many of our faculties are doing here. So we have a big group of faculty members, about 85 of us who are full-time with the School of Public Health, and all of us contribute to different areas in the school. So there is a biostats domain, an epi domain, health systems and policy domain, and social behavior and sciences domain, which acts as departments of the School of Public Health, and most of us belong to one of these domains. But actually, what's interesting in the School of Public Health is that the domains interact with programs and centers. And many of us are members of one of those, a couple of those centers and programs within the school. So for example, during COVID, the infectious disease program became very, very popular and, working quite closely with the Singapore government. But equally, I think many of us knows that NCD is a big problem in Singapore. So the physical activity and nutrition determinants in Asia program is very popular as well. So that's PANDA for short. So other than that, I'll just quickly go through some of these centers and programs and the kind of activities that they're doing, which is beyond the work that I do as a researcher within the School of Public Health in NUS. So the work that we do, we're quite fortunate to be able to interact research and practice. And the school started quite a lot of the work being focused on the national interests of Singapore, but soon later on actually grew its interest to work on global health issues in the region. So I would say that, we do champion a lot of the policy-directed research within the Ministry of Health, and we are very lucky to have the Public Health Translation Team and Practice Office that focuses quite a lot on the work that the Ministry of Health in Singapore requires. So yes, our main partner is the Ministry of Health, but we also partner quite closely with the Ministry of Manpower, Ministry of Defense, Ministry of Environment, and the other different intersections within health. So like the Health Promotion Board, different health clusters, and also some overseas government agencies as well. So we do meet them yearly and we do present to them thematically on the different issues, either around the space of ID, around the space of NCD and health promotion. And there are always very, strong working level meetings that happens around joint areas of interest between both colleagues at the Ministry of Health in Singapore and also colleagues at NUS. And for some of us, we have joint appointments with the Ministry of Health, so that allows us to really understand what the ministry needs. So to us, it is really important to engage our government at least in understanding how research can actually translate into policy. So I now would like to just share a little bit more about the new ventures that we have been going into global health. So we've been working and we're committed to actually working in the region, especially in ASEAN, and hopefully at some point in time really go beyond that. And we really look at the kind of international research, training, and practice activities. So, for example, here we've got overseas offices in Phnom Penh, Cambodia, in Vientiane, Laos, and in Manila, which will soon, hopefully next year, we'll be able to set it up more formally. A lot of the work that we're doing is really around capacity strengthening in ASEAN and training them either in Singapore or regionally. I'll share a little bit more about the Cambodia program, which has been around for about 11 years now. It first started off really specific to infectious diseases, but expanded more broadly to look at other issues that are relevant to the Ministry of Health in Cambodia. So we do it in partnership with the University of Health Sciences, so Professor Svantanak School, but also the National Institute of Public Health more recently. And a lot of our activities we work closely with them on that. I lead the Lao PDR office, so we started this about 3 to 4 years ago, and we took a different stance to it. So we worked with the Ministry of Health to understand what are the areas that they felt were important, and they felt that the School of Public Health in Singapore could work with them on, and how do we partner then with the National Institute of Public Health equivalent, which is the Lao Tropical and Public Health Institute, to understand what kind of joint activities can we do together. So we have a physical presence in Lao and a big group, about 10 people now working in our office in Lao about, and really working very closely with our partners. Many of them are Laotians, and I hope at some point in time, a Laotian will take over to be the lead. We are very excited about the future opportunities in the Philippines. So really hoping to be able to launch this more in 2026 under the leadership of Dr. Harvey Limong. So hopefully we'll be able to also work quite closely with our colleagues at ADB a little bit more. But really areas to identify, work with the DOH, PhilHealth, and other partners within the Philippines. So I think we do have a growing portfolio in global health. We do have close partnerships in Thailand, especially with High Tech Foundation and IHPP Foundation, and really looking at HTA capacity building, so health technology assessment and research. So we also are co-organizers of the PMAC conference, which is the largest global health summit in Asia, and we partner with our colleagues in Vietnam Ministry of Health, so Health HSPI, quite strongly to look at how we can generate evidence to support policies either around tobacco, nutrition, or health financing. We do have a close relationship with the Ministry of Health of Brunei, where we provide regular technical assistance as well. And some of our colleagues are members. We are WHO Collaborating Center on Occupational Health, where some of my colleagues do quite a lot of work in that space as well. Again, some of the strategic areas are across really health risk communication, sustainable UHC, health promotion, all the way down to evidence-informed policy design. And here we look at things like school health program, health security and pandemics, and vulnerable population. So I think just some last slides that I just want to share a little bit more about. We host Singapore's largest population cohorts that allows us to look at epidemiological factors that are important to the Singapore population. And here, again, the National Cohorts Office is also hosted within the School of Public Health in Singapore. And we also host the Asia's largest clinical trial network, where we have about 140 sites across 24 countries that was launched about 4 or 5 years ago, funded by Singapore's National Medical Research Council, together with the Wellcome Trust, the Temasek Foundation, and several different important foundations and industry partners. So in this clinical trial network, the whole purpose of it is to study, either things like AMR, antibiotics, and trial them out in a hospital setting. And here we've already recruited more than 12,000 patients worldwide. We also host the Asian Center for Health Security, and this really looks at things like the Lancet Prime Commission, looking at education, how law and governance interacts with pandemic preparedness, biosecurity, and risk management. I'm part of the Center for Epidemic Research and Modeling, which is the largest modeling center within Asia, which contributes to work in national and international pandemics. So you have about 11 faculty members there, but within themselves, they have about 10 to 20 people who are part of their team. So we have about 100 to 200 members of CERM. And the purpose of CERM is really to look at how can we do better for the next pandemic. And we are also the hosting member of MIDSI, which is the modeling of infectious diseases in Southeast Asia. And most recently, we were actually in Yogyakarta for our MIDSI event. So very nice. Thank you so much to UGM colleagues for meeting us there as well. Most recently, we've also set up the first Center of AI and Public Health in Singapore. And this is really looking at thought leadership around governance, regulation, and ethics, and the different unique cases in public health. So here we're also looking at evaluating several solutions. So looking at, cost-effective introduction and implementation of AI more broadly, and how do we scale pilot to larger scale activities. We also have a center on environment and health, and here we're looking at the interaction between environment, climate, and different infectious diseases, and as well as non-communicable diseases within the region as well, because we know that that's a very important space. So at the end of the day, we recognize the importance of actually health economics behind all of the kind of interventions. So Hyper has been around for at least 5 to 6 years now, really looking at conducting training around HTA, health economics financing, and looking at the impact evaluation behind many of the programs that are being implemented around the world. So I'll end there by just really thanking our organizers for having me here. Yeah, happy to take questions later on.
Thank you, Keisha. Very impressive range of work. So thank you for sharing that with us. And let me also mention to our participants whose number has exceeded 100 at this point, amazingly, that you can post questions in the Q&A, which you should see on your screen, or if that's not available, in the chat. And Ian Evesco from CUGH is helping us to manage some of this information as it comes in. So thank you, Ian. Let me now turn to Professor Laksono from Indonesia.
Okay, thank you, Peter. Yes, I think I try to yes, maybe describe my personal journey and then our university, the CUGH in Indonesia for, yes, presenting about 30 years of experience in health policy, policy advocacy. So I was trained as a medical doctor, and then I went to University of York in early 90s, and then finishing PhD at the London School of Hygiene and Tropical Medicine for a PhD in health policy. So this is the beginning of what we called as a health policy is becoming a new science in medical school at Gajah Mada University. Okay, but I started when I am returning back from UK, not like researching in health policy, but more in health service management. Because actually, health policy, in my opinion, is rather difficult at the time. It's not yet clear about the black and white of policy. So started with health management is much easier because management is not too much politics there. So the wrong and maybe right is more clearly, yes. So 37 years ago, we established the Center for Health Service Management. But this is a big part. I felt that some of the policy at that time in a decentralized Indonesia, we have a national, provincial level, 30 province, and more than 500 district and cities. I felt that some of the policy are not good. Yeah. So that means we have to influence the policy making process, not becoming only like a spectator. Yeah. So we have to like influence the policy making. So after 12 years of the Center for Health Service Management, so we changed the name into Center for Health Policy and Management. Center for Health Policy and Management. So both names, policy and management. And the directorship changed to Professor Yodi. He will be the second speaker in the second session, Prof. Yodi, and he is the Dean of Medical School at the moment. So he is my successor in the center, but directly lead the policy development of our faculty. Okay, so between 2010 to 2012, 25, more than 15 years, we developed what we call like evidence-based policy making, evidence for policymakers, capacity buildings to create. Yes, this is a very important issue that we don't have enough resources for policy research, leaderships, and also what we call like a knowledge management of the health policy. So we did a lot of things, maybe hundreds of programs and meetings, and the team is from decentralization, health financing, UHC, medical education policy, TB, diabetes policy, like disaster management, and also the controversial healthcare reform in 2023. Yeah. So when we look at back to the 25 years or 30 years of experience, then we can see that we have so many challenges and also problems. We have some like not nice relationship with government because the policy we were set is not good. So sometimes we have a very conflicting position with the government. But suddenly, during COVID, I was recruited as a special advisor for the ministry for 3 years between 2021 and 2023. And that is the time for me to look at how policy making is done in the real world. So becoming like high-rank officers in MOH provide me with some of the nice experiences. Now, after returning from a 3 year sabbatical period of in MOH, then I'm still tracking the way of doing policy research. But the biggest problem at the moment, how to keep my independency after my sabbatical times in the MOH, because I'm returning back to be a policy analyst, not a policy maker. Okay, I think this is my presentation. Thank you, Peter.
Very good, Laksono. Thank you very much, and also for sharing your personal experience of actually leaving the university for several years and joining the government as an advisor. And I think this is an interesting model and example for others to think about. So before we open this up, our last, by no means last speaker is Professor Carlo Panelo from the University of the Philippines. Carlo, please, the floor is yours.
Yeah, thank you, Professor Berman. Thank you also, Dr. Martin and CUGH for this privilege to join this illustrious panel. I'm very happy to also touch base uh, with very respected, mentors that I've met along the way, Professor Sunman, Pak Laksono, Pak Yodi. It's great to touch base again, even if online. Um, I have 3 points. First is that the relationship between the university and government agencies, particularly in health, has actually been mutually beneficial. On the side of government, of course, the university helps government expand the scale and scope of its programs, with the universities enabling a force multiplier effect by first producing health human resources that actually operate or serve in the front line. The universities, in our experience, also generate evidence at varying levels and at varying, uh, you know, parts of the policy cycle, and including implementation science. Although, as Dr. Banson mentioned earlier, I think in the case of the Philippines, it's more implementation support that's the predominant form of engagement between universities and government agencies. And um, in return, the experience of faculty members, staff, and even students who get exposed to the work that happens as the universities and government agencies interact also enriches the curriculum. It helps ground the courses, not only in terms of the material, but also provides an opportunity for people from both sides of the fence, from government as well as from the academe, to actually share a common platform and directly interact with students, showing the synergy between universities and government agencies. The second point is that I've noted that the level of engagement between the universities and government agencies also ebbs and flows over time. In the case of the Philippines, my view is that it's driven by long-term professional relationships. You know, people who have been working with each other over a long period of time establish this sort of working relationship that goes beyond or spans across multiple administrations or government changes, and uh, and also personal networks itself, meaning whether they come from the same school or graduated from the same school or went through the same training program. And the third one is that as the university and government agency relationship deepens and the scale and the scope of activities that they do together expand, um, there is really the challenge on the side of the universities to strengthen its administrative capacity to implement larger projects funded by government, because their systems are usually not attuned to getting money from a government agency, for example, and then executing a project and being accountable for deliverables in a timely manner. And in the case of direct implementation support, essentially the university internalizes the deadlines that are imposed on a government agency that's mandated to actually um, deliver services. In the same way that its human resources for health policies would also need to adapt to these kinds of changes. In my personal experience, um, in the early part of my career, I had to go on a secondment or a leave of absence from the university in order to work in a policy project, which was funded then by USAID. So while I was away for 5 years and was allowed by my university to work on this project on a full-time basis, it also affected the continuity of my service with the university. And so I have a sort of a gap. Uh, I think that as we move towards a deeper or stronger, tighter engagement between government agencies and universities, at least in the case of the Philippines, we need to find a way for faculty in the universities to have different practice tracks, as there might be some faculty members who are more attuned to just focusing on teaching or spending more time in research and or spending more time in what we call as extension services. In the case of the National University where I belong, and where Dr. Banson and I taught, I actually inherited Dr. Banson's position when he moved to PhilHealth. Um, we have a threefold function, which is teaching, research, and extension. Extension is the term that the university uses to classify different types of activities that involve uh, helping government implement, and that's part actually of the mandate of government faculty. Thank you very much. I'll end there for now.
Okay, thank you, Carlo, for those very insightful comments. And I'd like to just offer a couple of observations cutting across what we've heard. And then our panelists can certainly chime in with some further responses or reactions. Probably just chime in or raise your hand and we'll turn over to you. And then, of course, we do have some questions and opportunities from our audience as well to discuss. Let me just offer a few thoughts about several things that people have said. Clearly, the old idea that the university was somehow an ivory tower, which was somehow removed from the concerns of the world and a quiet place for reflection and research and generation of new knowledge, has been changing. And the fields of medicine and public health and health policy and systems are clearly areas where that change is not only visible, but necessary. And you all have talked about not only research, but the importance of work in education and in practice and engaging with government and also non-government actors in the health system. And I think we have to recognize that this is not only something that is taking place, but it is something that is necessary for the university to make its contribution to the world and to the countries where you are based. And of course, many universities are supported by the taxpayers, the citizens in your country, and they need to perceive the value of the work that you do. So this is very important in many ways. And we need to welcome this transformation of the role of universities, not try to reduce or hide it or oppose it. That's my personal view. I'd also like to comment a bit on some of the issues that Sunman raised about the challenges in the university environment. So it also requires the universities themselves to recognize the value of this work and to reward and recognize and incentivize the faculty members to do this kind of work, in addition to or in complement to the knowledge generation and research work that universities do, which is so important. And I also wanted to add a comment about politics, which Prof. Laksono mentioned to us, and Carlo also mentioned that, we sometimes view politics as a problem or something to be encountered with a bit of trepidation. In my view, we shouldn't see it that way, although sometimes that is what happens. But politics is also the mechanism through which citizens and other groups in society express their views and their needs and their demands. And it is an important factor in trying to make health systems improve and perform better. Of course, it doesn't always get things right, but another thing to keep in mind is that politics does change. And so sometimes when we feel most discouraged, we might take a deep breath and say, okay, I'm waiting for the next round and the next opportunity to do my work. So let me stop there with my thoughts and response to some of your comments. I do know that Dr. Keith Martin is on the call, and Keith, I would be remiss not to give you a moment to reflect if you have something to add at this point, but that's up to you.
Well, thank you very much, Peter. I'd like to really thank you and Professor Sarkar, both of you, for all of you who are on. We're very lucky to have Professor Berman and Professor Sarkar on our board. Both of them have been working tirelessly to engage colleagues in Asia. And I'd like to thank all of you who are panelists, all of you who are attending. We know it's late in the day for you, but we're extremely grateful that you made the time to be able to participate in the session. It is part of an ongoing effort, as Professor Berman mentioned, of our deep interest at CUGH to engage with our colleagues in Asia. Frankly, it has been a gap for us. Part of it is the time zones that we have, but we're determined and committed to be able to forge those relationships. Second, on the issue of implementation science, both Professor Berman and Sarkar have been leaders within our organization to do that. We're very committed to being able to interrogate the issues that you have been dealing with on the session and finding ways practically, as Peter just mentioned, and how we can at CUGH be part of an agency with you to reform academic institutions, to be able to find out what are those incentive structures that enable our colleagues in academia to be able to engage not only with policymakers, but with other organizations to bridge the gap between research production, policy development, policy implementation. And finally, also one vexing challenge that we haven't been able to figure out, but we'd love to, because we certainly see that there's a great opportunity to be able to connect the technical capacity within universities with public servants. Not only as was mentioned with ministries of health, and I was very interested to see that you had defense in there too, which was great, and also other ministries. How can we think through and connect the capacity, the technical capacity within universities to be able to work and strengthen the public service so that countries will be able to have the engine and the mechanism, the financial and management structures to be able to implement the public programs their citizens want. So thanks very much, Peter, for giving me an opportunity for having a few words with you. And again, much thanks to you for organizing this wonderful panel. I'm learning a lot. Over to you.
Thank you. Thanks, Keith. Malabika, do you want to say anything at this point, or come in later?
Thank you. Later, yeah.
Okay. Let me turn it back to our panelists. Would any of you like to follow up on some of the comments that have been made so far and give some more of your own views and experiences? Please chime in.
Hello, Peter, yeah.
Dodo or Luxono. Dodo, go ahead first. You go ahead.
Thanks. I thought Lacsono will go first. But Dana,
We're all friends.
No, there are two, in a sense, okay. So for universities to really be to sort of input to what government wants, and I think this is within the particular context of Asia that I'm talking about, right? So in Asia, Asia, in a sense, Asia countries, which we in ADB support, has really progressed on what they want to do, right? So the setting may be different in other parts of the world. But in Asia, most countries have committed, for example, to universal health coverage. You go to an Asian country, you hear them, you get so excited because they have all these reforms from financing, service delivery, and all that. Lacsono is part of the health system transformation agenda in Indonesia, big time reform. Same thing in the Philippines. Carlo being a champion of what became the UHC law. So in a sense, in Asia, the approach where you have universities coming in to introduce new ideas and concepts is sort of not the way to go. really the challenge there is like how can you help these countries now as universities move forward? And I think there are two, so in a sense, how to respond to the context of universities. And I hear two ways in which where I have actually seen two ways. The first one is more Asian. It's what Carlo is saying, what probably what Laksono is saying. Really relationship. Political leaders trust people who they trust. So if you are a known entity to those who are the Minister of Health or the Secretary of Health, like in the Philippines, and you're in the university, they will listen to you. And you actually even used by the other advocates as champion as the way so that the particular researchers are listened to. So in a sense, this personal relationship, I think it's also common in other countries, but it's also very Asian. The second, and this is something new that we're seeing, is what Asia is doing. Because I have always criticized Asia also that we don't have enough centers. That when there are certain questions that needs to be asked, and the experts that we have don't, the university people don't have those answers, then we have no choice sometimes but to reach out to people, and you get a lot of off-tune advice sometimes coming from experts from outside Asia because we have not really built those centers, which you have seen, for example, in Harvard or in London School, where Laxona came from. So I really love, not because I am also working with NUS, what NUS is trying to do, really build these centers. So because the NUS already knows where the questions are coming from anyhow. And so hopefully when countries have problems, and those problems would come. The same problem, a lot of problems countries are having in Asia have also happened in Europe, in the US, Latin America, in Korea. So in a sense, we hope that we'll have more of these centers in Asia. So it goes beyond the personal relationship, which is where it is right now, most of the time, to really more center-based approach of NUS. I'll stop there.
Thank you, Dodo. And Laksono, over to you.
Yes, I think we have to give some emphasize on we have to be very patient. I think we as the university researchers in health policy, in my experience, in one case like the data of equity, it is very political. It is very political, and in my experience, it took about 12 years for me for convincing people in the government. Okay, but when I enter the government, like in a cycle of policy, it is easier. So that is the point. 12 years of presenting the problem of equity using hard data, it is so difficult to convince policymakers. But when I, yes, put into the circle of policymaking, it is very easy. So there is like a direct conversation between me and the minister. I don't know, in other countries, is it difficult to convince the minister about something that politically is difficult? This is my point, of Peter. Yes.
Okay, thank you. Let's see if our other panelists have anything to add on that. Carlo, you've had experience working with political leaders in your country.
Yeah, I second the points raised by Dr. Banson and Pak Laksono earlier. I mean, it's not an easy job advising, especially at the higher levels of government, or even actually at the lower levels where decisions are made. Because at the end of the day, as university professors, we have to realize the fact that we are not the ones making the decision. We are not the ones accountable to the constituencies of the principals that we advise, and therefore they actually weigh a lot more variables in their decision making than the evidence. But I think what the role is of advisors in this sense is to make sure that the evidence is clearly understood, the options are presented, uh, to the extent that we could, given the relationship and the level of comfort that we have with our principals, to push for the ideas that we think are correct, but to also give leeway to the principal once decision making is at the brink, because they're the ones that are accountable to their constituents. Thank you, Professor.
Thank you, Carlo. And I do think, one of the advantages of working in this policy world is that we learn what are the broader concerns that the administrators and political leaders have to pay attention to. So it's important to learn that. So Sunman, you are next. Please go ahead.
Yeah, I mean, kind of echoed what has been already commented because I think there are slightly different levels of health systems research, and for example, macro level, meso, a bit micro level. Probably I can comment on the academic challenges, but from a policy challenge, I mean, I think I'm not a clinical. I don't have a clinical background, as I started as an economist doing a lot of micro econometric works. But over the stage of my academic career, I become more and more on the meso and macro level policy and systems research. And also, I think that if you are really interested in policy or want to impact the policy making, we all know that health policy is driven not only by evidence, but also a lot of value judgment aspect. So in that case, when you emphasize and fully appreciate the role of values and not only the formal but also informal rules of the game and policy making, then at certain points, some department or group of researchers or even individual researcher has been viewed as okay, that person has a strong view, strong perspective of this way of the health system development. And then I think at certain point it becomes a bit inevitable that the role of us academics also depend our impact or role depends on the change in government. I mean, for example, like Sono mentioned, the role of equity. For example, my department at Seoul National University has been viewed as that group has a very strong emphasis on equity. Although we do a lot of empirical works, but evidence generation, but still, many of our colleagues have a very strong attitude toward that the equity is so important. And then if the government, for example, previous government is very much of a liberal, market-oriented efficiency, then at certain point, we have difficulty impacting or collaborating with that government. So, of course, as I'm saying, that our main role is evidence generation, evidence-based policy, but at certain point, health policy and systems research cannot be perfectly free from values of health systems. And then we face challenges in impacting, influencing the policymakers, because depending on the government or political leaders or political parties, their emphasis is also different. That is inevitable challenge for us. Over.
Thank you, Sunman. I think very insightful comments, and I think this does raise the importance of understanding ethics and values, and understanding where we are in the range of ethics and values. As you know, in our work on health systems, we included ethics very much as something that we professionally need to pay attention to. Thanks. Keisha, go ahead.
Thanks. I think, all the panelists actually really shared, and including yourself, Professor Berman, on really interesting aspects to it. And I thought maybe I can use this opportunity to answer one of the questions that was in the chat earlier by Professor Kamaraju on how, the ways in which we are handling the cost of cancers in our country. So I feel that within Singapore, there's a lot of importance dedicated towards justifying the value of cancer screening and treatment that the Ministry of Health has actually asked us. And we know that within Singapore, you're starting to see a huge demographic shift towards older population. So I feel that, we are working very closely with the Ministry of Health to build a portfolio to take the finance to the, a series of evidence to the Ministry of Finance so that they can justify and mobilize financing for cancer screening and treatment that is cost effective. And I think that's something that's really important as well. And how do you not directly play into the palms of the pharmaceutical companies and, make your own value judgment based on the kind of, technologies you're able to afford. Yeah, just wanted to comment a little bit on that.
Okay, thank you, Keisha. So we have a little less than 10 minutes left in our session, and I would like to signal to Ian if there are any of our participants who would like to come in with questions, most welcome at this point.
Sure. Yeah, I've been monitoring the chat. I think a lot has been addressed. There's one question in the Q&A that Professor Pinello addressed about the gray area with idealism. Looking to see if there's anything else, but I think a lot has been covered.
Okay, that was a good question. How do you maintain the balance between academic idealism and advising in health policy? And Carlo did type in a very valuable answer, ensuring that we are honest brokers and are transparent with evidence and practical, looking for solutions and respectful of the challenges that governments face in balancing many different interest groups. So I think that we should not see idealism as a irreparable conflict with practice, but rather navigating the voyage between idealism and practice is actually more of our role in health policy and systems advice. I don't know if any of our colleagues would like to add any further thoughts on that.
Yeah, I think, Peter. So I think
Go ahead.
ideology matters. Yeah. Yes. In terms of equity, for example, if we can understand that there are many voices of which one is the equity principle, but I think we have to put more in ideological context. Like our university is more socialism than maybe the other university. So there are some different views of equity. That is the point. Thank you.
Yeah. Okay. Anyone else want to chime in on that one? Okay. Professor Martin, Dr. Martin raised the question, what are the incentives that might promote universities to collaborate more with governments and others on policy and systems development? And Carlo responded that funding is, of course, one of them, but let's give others a chance to comment on this from the perspective of your universities. I know that I asked Prof. Laksono this question, why in Indonesia it seems that government has been so receptive to putting professors into leadership positions, and whether this is true more widely across the region. I think this has been the case in Korea as well and in the Philippines as well. So this is a very interesting phenomenon. We don't always have this happen in the United States so much. So any thoughts on that?
Yeah, I think in Indonesia, Ministry of Health is not a political ministry. So usually a technical people that becoming the minister, not the politician. But if you go to the industrial ministry, it is very political, or maybe the local government ministry is political. But Minister of Health usually is more technical person, not politician. That is the maybe one of the reasons why so many professors recruited as the policymakers in MOH. Yeah. Yes.
Interesting.
I think in the case,
Salman, go ahead.
In the case of Korea, I think it's not just the Ministry of Health, but sometimes other ministries also. We have a presidential system, so presidents sometimes kind of call the academics to be the minister, not just in health ministry, but other ministries as well. One of my explanations is that we have a bit of still confusion culture, such that sometimes I feel the president still, general public think that, well, that if a professor is appointed as a minister, okay, this appointment is not driven politics, but like this government really appreciated expertise. Sometimes it's true, and sometimes it's not. And some professors from academic background, he or she does a good job. Sometimes not at all, because policymaking is not just a technical issue, but a lot of politics in the ministry. So some failures, some successes, mixed result. Over.
Okay, thank you. Any other panelists would like to comment on this?
Professor Berman, if I can just add a few
Please.
inputs. The Philippine system is prone to political influence because by the structure of our government, um, officials within the agencies from the director level and above are considered presidential appointees. So you may come from the bureaucracy, but you have to get a presidential appointment once you reach the director level going up. And almost always, the Minister of Health or the Secretary of Health, there is always a new appointee each time there is a new government that takes over. But this is also a double-edged sword that can work both ways. The good thing with fresh infusion is that um, the bureaucracy is sort of like renewed each time under a new term with the possibility of having new leaders. And this is where most of the academic, with candidates with academic backgrounds get into the bureaucracy and serve for a short while. And enrich the culture of the agency with this cross fertilization as opposed to having the bureaucracy purely populated by people who have been in the agency for most of their professional careers. But the risk is that certain programs would be discontinued as one administration takes over another, as the flavor of the month varies given the ideology or the preferences of the new leadership would set in. Thank you.
Thank you. Well, I'm going to toss in one quick thing with a little over a minute remaining for any brief comments, and that is we talk a lot about the relationship with ministries of health in our field of health policy and systems research. What do we need to convince the Ministry of Education about what we do? Anyone want to comment on that?
So, Professor Berman, given less than a minute, let me just take a quick jab. If we want to intervene in health and prevent a lot of illnesses that usually bite us when the population ages, we need to start with education and teach healthy behavior in that setting, and also provide interventions that make children live healthier childhoods and teen years that eventually result in higher economic productivity when they enter the labor force. But more than education, we also need to look at other agencies as well, particularly the Department of Finance and the Department of Budget or its equivalents in other countries, as a lot of the health functions right now are so dependent on the available financing and influenced by financing policies. Thank you.
Thank you. Well, I know that we're just about out of time, and out of respect for my dear colleague, Professor Malapika Sarkar, I don't want to exceed our time. I want to express my thanks and appreciation to my dear colleagues and friends, our panelists, Laksono, Carlo, Eduardo, Dodo, Sunman, and Keisha. Thank you so much. Excellent panel. Please stay with us if you can for the next hour on implementation science. And my clock says 9 o'clock. Professor Sarkar, over to you.
Thank you very much. Thank you, Peter. And after listening to such an exciting
Thank
and
you.
insightful conversation, I think it's a good transition from discussing the health policy to the institution, that academic role of academic institution. And it's my honor and great pleasure to welcome my panelist. One of the panelists is still did not join, but I hope he will join soon. So I would like to introduce, I will have a brief introduction of my panelists, because I know that you can go to the website and you will find each of these panelists, the brilliant and very well-known academics, those who are engaged in implementation science and implementation research for last decades. So let me start with Professor U.D. Mohandatta. U.D. Mohandatta is the Dean for Faculty of Medicine and Public Health and Nursing at University of Gadamacha. UD also leads the WHO TDR Capacity Building Regional Center. And as a clinician, UD has kind of engaged in a series of clinical research, but also implementation research. Thank you, UD, for joining this panel. Then Professor Archana Shrestha. Professor Archana Shrestha is the professor and also the Director of Public Health Program, Kathmandu University's School of Medical Science. Professor Shrestha is also an adjunct faculty and regularly teaches at Yale School of Public Health. And again, an excellent implementation researcher, a great epidemiologist, and leads a series of hybrid the implementation trial in Nepal and multi-country studies. And then I have the Piyusha Majumdar, Associate Professor of IHMR University in India. The Piyusha is also very well recognized implementation researcher, but her contribution in capacity building is it's leading in Asia. That Piyusha leads TDR capacity building program in IHMR Jaipur. And as an anthropologist, Piyusha also contributing in implementation research. So oh, wow, great. Now we have the final panelist, Professor Roman Shu. The Professor Roman Shu, thank you. Welcome, Roman.
Sorry, I had a great difficulty log on to the system. Sorry.
No, that's okay. There's only 2 minutes. So, Professor of Global Health and Health System and Director of at the Institute of Global Health at Southern Medical University in Guangzhou, China. Professor Roman also editor-in-chief of Journal of Implementation Science Communication. But I think his major contribution in implementation science is development of this framework called PEDAL, the problem-based that implementation research. And so with the four the panelists, I will start this modality is more about the role of implementation research within each country. And I have a series of the question that I will ask to each faculty and in relation to their institution, the academic environment, but also we had heard a lot of discussion about how to collaborate with the government and the policymakers and the politician as an academic in the previous session. Maybe some of the discussion will, again, we will go through that. But at the same time, I also want to acknowledge that our Professor Peter Berman is here. He was a professor at Harvard and is one of the, I would say, that lead health system researcher globally, especially his work in South Asia and India is enormous. Thank you, Peter, for staying here. And also the Keith Martin. Keith Martin is the executive director of Consortium Universities of Global Health. And I'm on the board of CUGH along with Peter. And this is an initiative that for expanding the global health education or learning led by CUGH. So my first question, I will start with Roman because I know that your leading role in China, you had multiple hats. You were in China Medical Board, now in Southern Medical University. And recently, we just hosted the largest, the first Asian conference on implementation science hosted by Professor Shu in Guangzhou. And Professor Yudi and Professor Archana were there. Unfortunately, Professor Piyusha could not join. But just in implemented research, we always talk about the context. That's the foundation and the backbone of implementation science. So the first question to all four of you, but I'll start with Roman, that what are the unique contextual feature of your national health system to shape the design the implementation research in your own country, in China? Roman.
Thank you. It's first I want to apologize for logging into the system late. I had some difficulties of get onto that. In terms of some of the unique contexts where implementation science is happening here in China, I like to reflect it a little bit into the deep history in Chinese philosophy. I think China is sort of in the place where implementation science is sort of bounded to take off, in a sense. We have an ancient philosopher. His name is Wang Yangming. His main theme of the philosophy is doing. Knowing is not enough. Doing is something make it happen. So he's tackling basically the no-do gap. Many years ago in history. Then in the modern Chinese history, particularly since 1980s, China entered a period called reform and opening up. Because before 1980s, China was a sort of closed and everything was by the book. But since 1980s, Chinese economy began to take off. One of the key successes reason is Chinese really take a pragmatic approach to everything. And the paramount leader Deng Xiaoping said, no matter it's a white cat or black cat, as long as they can catch mouse, it is a good cat. So I think those broader environment set up a mentality in the Chinese mentality. We need to get things done. That broader context actually make many of the implementation in China easier in my sense, because everybody in sort of in the mentality, we want to do something, make change, and get things moving forward. There are many other contextual factors, determinants, barriers, facilitators. But for the time being, I want to stop here because just want to mention those broader societal, philosophical, and psychological mentality is an important influencer for people to develop the field of implementation science and also to get things done.
Well, thank you so much, Roman. That's also says a lot about that how a country can proceed with a new field like implementation science, which is built on or guided by their own philosophy. Same question to Professor Archana.
Yeah, thank you, Dr. Malavika. It's been, so first of all, thank you for inviting me in the discussion. So talking about implementation science in the context of Nepal, so not just the implementation science, but in the academic field of Nepal, even research is still evolving. We are currently moving forward, advancing into the research and implementation studies, both in academia as well as in the development field, as well as in the Ministry of Health and Population. So I would say that it's in the evolving phase. But there is a lot of opportunities and at the same time, a lot of challenges that has both contributed towards advancing implementation research within academia as well as outside of academia. Historically, Nepalese health system has been predominantly governed by a lot of external funding aids. Specifically, like if we talk about the USAID and other funding sources from all around the world, and a lot of agenda was set by those funding agencies. When we look at the programmatic aspects and policies within Ministry of Health, a lot of those were also set and prioritized by who was funding what over the years. However, with these recent changes, like globally, the recent changes, a lot of conversation is now shifting towards more country-led research and country-led programmatic aspect. So in Nepal, we are growing. and at the same time advancing and establishing implementation research, not just in the academia field, but there is huge interest from government. For example, our Nepal Health Research Council, which is the apex body of research in Nepal, has started a implementation science training program to train non-academicians within the country. And then we are collaborating very closely to train non-academicians as well as academicians together as a peer so that they can learn each other. And we are moving more towards the embedded implementation research, meaning conducting implementation research within the current health system in Nepal.
Oh, I think that in the previous session we discussed about how to engage the policymakers and politicians, but that's the way to foster that embedded research. Yeah. Professor Yudi, same question for Indonesia.
Sure. Thank you, Malabika. So I just want to highlight why collaboration research is increasingly in demand in Indonesia, mainly because of the context itself. So first of all, Indonesia has an extreme geographic diversity because we have the largest archipelago in the world with over 16,000 islands. So in principle, any interventions need to be locally adapted because what works in the Java island may not work in remote Papua or island communities with limited access. That's one. Second, in our health system, we have a highly decentralized governance, meaning that districts make most of the health decisions. So there are variations in leadership, capacity, and political priorities, which often determine whether interventions succeed or not. So their understanding of local political economic context is essential. And third, our large national health insurance scheme, the JKN, creates a strong financial incentives that shape profit behavior. So any interventions involving healthcare facilities must align with benefit packages and also must align with reimbursement rules and cost pressures. And finally, strong community structures from village cadres to religious network, they all play a major role in shaping feasibility and acceptability of interventions in Indonesia. So in short, the Indonesian context in essence requires interventions to be co-created, locally adapted, and aligned with real-world system incentive. And that's why implementation research is much needed and increasingly in demand in Indonesia. Over back to you, Malabika.
Thank you, Yudi. Piyusha, the reason India, the implementation research has not blossomed or has not expanded the way that other Asian countries. I know very few implementation researchers who are engaged in implementation research, and one is you. Why do you think that India, like Indonesia, has such a diverse country with the culture, the language, the geographic barrier, and there's so many interventions that the good public health interventions are going on in India. The why?
First of all, thank you, Dr. Malabika Sarkar and the CUGH team member, Dr. Keith Martin, for inviting me and giving this excellent opportunity to contribute to this panel discussion on how Asian universities are strengthening the future of global health. And Dr. Sarkar, as you said that, India is not blossoming, but I would like to say here that implementation research is quite in demand in India. Our government, Ministry of Health, and the other research organizations like Indian Council of Medical Research, they have their separate division on conducting implementation research. So it's not like this that we are not doing, we are conducting implementation research, but the major challenge that lies, is, our health system. And, as you know, that we have a three-tiered, public health service delivery system. And the interventions, they have been, mapped to these service delivery systems, whether it's sub-center, health and wellness center, PHC, CHC. So basically, what happened? If we talk about the unique contextual features, so
we have geographical challenges, socioeconomical challenges, cultural factor that basically shape and design and implement the health intervention and innovation. So when we design our intervention, so it is if there is a geographical challenge, then accordingly, interventions are designed with population's vulnerability in mind. But again, the challenges are more, and make policymaker understand that is also equally challenging as echoed by the earlier or earlier panelist. Though the interventions has been designed by specifically looking into addressing the disparity, whether it is gender, poverty, caste, or there are differential resource HR allocation also. But the real challenge lies with the people, and I think some more efforts are required to make implementation research more prominent in our country. But I think we are going to do this, and as it has been started in in China, we are also thinking of conducting a kind of a conference here, and let's see how it would work.
Thank you, Piyusha. So just to summarize that, it's interesting that how the national health system or the country that we have heard from Roman about the philosophy, the Orchona, that how there is an donor dependent, but then they embedded the research and the partnership between the policymakers and the academic. And UD mentioned about the geographic variation in Indonesia and India, the challenges in the different health system. But now my next question, that starting with UD, because you host the Regional Implementation Research Capacity Building Center in Indonesia, funded by TDR. How your institute, university, is fostering and nurturing the implementation research capacity building. And when I say that, most of the institution focus in their own institution. So many countries have this elite institution, in the low-income countries, are those who are equivalent to any top universities in the northern countries or doing much better, but there's not much on going on building the capacity of the other institution within the country. So my question is two level. One is the capacity building of the individual, but at the same time, capacity building or fostering implemented research at the other institution within the country, because all four of you represent kind of a leading implementation research institution in Asia. UD.
Okay, thank you, Malabika. So a bit similar. We start off with, of course, investing heavily on capacity strengthening in our institution first, in our university. I mean, as you mentioned, we've been fortunate to have the privilege to work with TDR since 2010. So we've been working on this for more than a decade. So somewhat we're at that stage where IR is semi-institutionalized in our university, meaning that it's part of the curriculum of our several master programs in our university. More and more master and doctoral students are conducting IR for thesis or dissertation, and has also attracted interest of academicians beyond the public health departments. Also the clinical, nursing, they're interested now in implementation research. But yes, we've gone beyond that because we've realized that the demand in Indonesia is great and we would not be able to address it ourselves. So we have been building some kind of an IR community in the country. Basically, we've been working with several universities across Indonesia to build up their IR capacity. But that's one side of the equation. That's from the academic institution side. If we talk about implementation research, of course, then the other side of the coin is also important, and the implementers, the program managers, and so forth. So the other part that we've been trying to do is to embed IR into national program and the policy processes in Indonesia. So we've been working very closely with the Ministry of Health to promote inclusions of IR in major health programs. For example, we've co-developed with the ministries a couple of times national IR strategies for prevention and control of TB, malaria, and TD. We also work with the ministry recently in rolling out their IR projects, which they are sponsoring to support the health system transformation effort, which is a major government effort. So we're doing both, trying to institutionalize it in different academic institutions in Indonesia and beyond, but also at the same time, we need also to build the capacity at the program side in the ministries. And that's how we've been doing it for the past decade or so. Over back to you, Malavika.
Thank you, Yudi. For the the audience, those who are researchers here, that Yudi also leads an implemented research leadership program. So I will encourage you to look at the profile, the web page, both for Yudi and Piyusha, that they lead the TDR funded fellowship and master's program on implementation research. Okay, Roman, to you for the Southern Medical University is kind of the PR and the leading institution in implementation research through your Acacia Lab and your and other college contribution. But how are you fostering within the institution and China?
Thank you, Malabika. We do have accumulated quite a bit of experiences in capacity building in implementation science in China. The implementation science was introduced by our team to China. It's basically about 5 years ago. So it was not 10 years, a decade or 2 decades, but it has ever since developed so fast. We now have something called a WeChat interest group in implementation science for researchers and students. We almost have 7,000 of them in the WeChat group. So basically starting from zero 5 years ago. So how did we come to today? One of the reasons is at the very beginning, 5 years ago, we organized the first training. Then we organized the second, third, and the fifth, blah, blah, blah. But the essence is not to organize the training, but we have a group of very dedicated champions for implementation science who organize the training, but also make all of those training openly available in the public domain. That has go a long way to promote the concept and idea. Second is most of those training are in collaboration with the big influencers. Who are those big influencers? The leading journals. Like we work from the very beginning very closely with implementation science and implementation science communications, the two leading journals in implementation science. So many of their editors participated from a very first initial training. And we also worked with NACET Global Health, NACET Regional Health in co-developing implementation science in China. Because those journals come with a big name in Asia and in China. So once they are participating, people feel, oh, this must be something important. So those key collaborators are very important to get the capacity building in the right place. The third is, as you mentioned, our team developed this pedals model. I think to get a science to take off in a given country, people have ownership is very important. So by developing pedals, one of the main thing is we develop something we Chinese feel we have sort of the ownership. So once we have that part of ownership, people feel more enthusiastic in doing that. And lastly, I think it's very important to have the champions. I have to emphasize that because we started with no additional funding, external support, but as long as there is a group of people who are willing to collaborate and support each other, traditionally, but even today, not traditionally, Chinese universities compete with each other fiercely. However, in implementation science, we have several universities with the key and the leading faculty members who are really working collegially in promoting implementation science. We share our resources, we share our curriculum, we share our students, we share our faculty members, we share our funding even. Then we conduct research together and using research as a demonstration in return for capacity building. Our first Asian Conference of Implementation Science is a very typical example of that. It's a collaboration of quite a few universities who are really working together. So I think those elements contributed to the success, I think, in at least attracting many people to be conducting implementation science. I think our next phase is really to make those 8,000 or 7,000 strong army to really generating good science. That is our next 5 years, what we are going to do.
Thank you, Roman. Piyusha?
Yeah. So, talking about how in IHMR we are fostering a culture of implementation research. So, we are inculcating the culture of implementation research by developing and also conducting management development program, training program, and capacity building program on implementation research, basically for the public health manager and as well as academicians. We have also integrated, as Yodi said, we have also integrated a module on implementation research and science in our MBA and MPH program. And as I said, we are offering, specialization in implementation science and implementation research because as a TDR, as a TDR partner. So after receiving this WHO TDR program, so we are building the research capacity of various students, diverse students, especially from Eastern Mediterranean region and Southeast Asia region. And we also have integrated our teaching material case studies into the executive Masters of Public Health course program. And this program is specifically designed for the government functionaries and working professionals who are working in the healthcare sector. So these professionals, these government functionaries and professionals, they are now trained in implementation research, who are now actually working with the health system, who are actually working with the Ministry of Health, international organization, and other organizations. And actually, they are utilizing the skill of implementation research to improve the health programs or public health, health systems in our country. And I also wanted to emphasize here that recently we have conducted a capacity building on implementation research for CIFIN member. So IHMR University is also a CIFIN secretariat, that is Southeast Asia Public Health Education Institutions Network. And we have conducted a capacity building program from April to May. And we have trained academicians, mainly academicians from Nepal, Sri Lanka, Myanmar, Bhutan, Thailand, and India. And I'm happy to say that Dr. Yodi was also one of the facilitator for conducting this capacity building program.
Thank you. Archana?
So in Nepal, so Nepal is a very small country. So as Roman said, we also had like officially introduced implementation research not more than 5 years ago. But we strangely, the implementation research was introduced by government in Nepal, not by the academia, which is, I think, would be a unique case here. So when we started talking about implementation research in a few years ago, it started with a training program and a grants program from Nepal government. The Health Research Council announced a training capacity building program alongside a hands-on practice and then provided some grant to different researchers who would apply. So there were 7 pairs of researchers who received the funding at that time and received the training. So it started with implementation research projects within the government hospitals and municipality, government, and community-based programs. And in academia, in fact, Kathmandu University School of our university started the credited courses within our master's program. And then now we have a consortium of 9 universities. There are only 9 universities in Nepal that has a public health program. So we have formed a consortium of 9 universities, and similar to CUGH, but at national level. And then we are constantly doing training programs like faculty development programs with in implementation, particularly focusing in implementation research. We have an annual boot camp where 120 students from all of the universities who are in the Masters in Public Health program come together, and we do a 7-day boot camp with them in implementation research. And we also have some thesis support grants program for these students as well. Alongside, we have a fellowship program where the faculty members of different universities they apply in pair with government to conduct embedded implementation research within their specific area, identifying an implementation research gap within their ongoing programs. So we are making few progress towards developing capacity like overall in Nepal throughout geography and throughout institution, like across different government, non-government, as well as academic institutions.
Thank you, Archana. I will ask you because there are a lot of participants maybe here, those who are listening, the students with mid-level career, and implementation research is a new field. So I'll start with Roman, that why is, like, I don't want to be a competitive field, but implementation science field now, epidemiologist, biostatistician, qualitative researcher, anthropologist, many clinicians, many disciplinary public health researcher from different fields is joining. Why implementation research is important, and what is the niche about the implementation research that one should kind of be excited about? Roman.
Yeah, well, there are many things we should feel very excited about implementation science, but clearly I'm biased. So I will share my biased opinion. First of all, I think implementation science is very attractive for academia here, at least in China. It is naturally multidisciplinary. In this Asian Conference on Implementation Science, we had a China session as a panel. Many people commented they rarely see the leading epidemiologist, health service researcher, nutritionist, evidence-based medicine top leaders, nurse leaders, pharmacology leaders. They are really sat together and talked with enthusiasm about implementation science. In China, normally the disciplinary silo is very high, tall, and strong. But in implementation science, those almost naturally go away. So I think implementation science is a natural thing to link multidisciplinary into one cohesive piece, because implementation science has to be addressed in a multidisciplinary way. So that's the number one, I think, personally, I also feel very attractive to me. But secondly, is implementation science is really dealing with the things we need. So when I was doing the other, because I started doing health policy service research in a generic sense under the global health setting. But when I'm communicating the message to other people, it's difficult sometimes to strike empathy. But when I'm talking about implementation science, I found out, particularly talking with the nursing team, the pharmacologists, clinicians, patients, policymakers, it's so easy to strike up the interest among them, because everybody can immediately have something, they can tell the story. Some evidence-based practice are not really adopted, maintained, implemented. Every individual have a story or two to tell about that. So if you tell them there is a science which is really focused on getting those evidence-based practice into adoption, implementation, and sustainment, people feel excited. Then if you say this is not something we just do it, we have an entire theory, models, and a framework and a methodology to support it, people feel even more excited. So to this, I think implementation science is really dealing with something which is missing in our healthcare system. For a long time, we have invested hugely in those generation of innovations, but not really let the existing innovations into use. So once we touch on that, people feel naturally, for many of the people, this is something important. There are many other things which make implementation science unique and important, but I think I will stop here so my other panelists have opportunity to talk.
Piyusha?
Yeah, am I audible? Yes. Why implementation research is vital or why it is important for our health system? I think if we really want that our public health programs, our innovation, they should make an impact in the community, then we would definitely think about conducting implementation research, because we know that there is a 17 years gap between what we know and how we do it. So in order to bridge this gap, it's really important that people should understand about implementation research, and people should conduct implementation research, so that we can actually improve the health system. We can actually work towards, there's a lot of digital thing that is happening in today's era, a lot of digital adoption. So one must do implementation research in order to find out how it is working, how people are actually adopting the innovations, if we really want those digital innovation or interventions to be succeeded. And then there are a nationwide priority. We have major national health program that is going on. So we are working towards like TB elimination. Now we have NCD. So in in our country, where we have where resources are limited, so we should definitely conduct implementation research in a real world setting in order to make those programs successful. We should also make, because implementation research, it is it can be helpful in addressing the equity gap. It is helpful in strengthening the community health, community monitoring, and also generating trust in the public service. So I think at the health system level, we must work toward implementation research, and we must train our public health professional on implementation research to make it sustainable, and also to make to reach our SDG goals timely.
Thank you. Archana?
First, I would like to share my own experience. I was trained as a very core epidemiologist and very, very quantitative. I mean, when I started my training in research, I thought that I can only do mathematics and work with numbers. And then in 2015, I started my first implementation science project, and it happened by accident. But after that, I have only been interested in doing implementation research, and I don't want to do any epidemiology, even though I hardly regard it. And for me, I think the base of that is what Piyusha just said, like the impact that you can create as a researcher. Like I always felt that I have been like playing with all this data, like drawing the conclusion, like I would do like a highest level systematic review, or I would do like highest level evidence synthesis, but from like there I would not see any tangible results. Like I would maybe make probably like a big publication and big noise out of it, but what after that? And I think implementation research is something that has given me the meaning of being like a real researcher, because I always I wanted to like do it rather like do more than like just publish or just like talk about it. So that opened up like a completely new avenue. And of course it is very challenging. It's nothing like doing like a desk review or analyzing data and publishing. It's so much more knowledge, skills, and expertise that we need. But and it is also exciting because every time we do a new research, we approach a new problem, we get into a new setting and new context, and the things that we had been doing like maybe 1 or 2 years ago, all of a sudden we realize that it doesn't work it anywhere. So there is a constant learning and constant innovation happening along with the process, and that process itself is also very exciting. So yeah, for me, it's clearly impact and excitement of like learning and doing and making progress.
Thank you. Yodi, finally.
Yes, thank you, Malabika. So if we talk about young researchers, early career researchers, and why they should go for implementation science, those who I interact with, I sense that there's a strong desire to make a difference, and implementation science is actually the way to go if you really want to be impactful, huh? Because it gives you the tool to actually make proven interventions to work better and more impactful. That's number one. Number two, I think, as Roman has also alluded, implementation science gives you the tool which is portable, which enables you to engage, interact with many disciplines, with many fields. So you might be interested in communicable disease, non-communicable disease, you might be interested in climate change, whatever, it applies. Yeah, so it makes it easier for you to work with different professionals, different subjects, because implementation matters in almost all of them. That's number two. And number three, which I think is no less important, is that implementations research basically also open pathways to leadership and global relevance, because implementation science is a growing global priority. I mean, you see it in WHO, TDR, and other major research networks. So young researchers with implementation science expertise can lead collaborations, shape programs, and contribute to global health innovations, and it advance implementation science, not just follow or apply, but also shape it. Over back to you, Malabika.
Thank you. So there are like a couple of questions. So I'll combine two questions. That one of the question specifically for Nepal, but I think also like in China, but for other countries, that there's still gap between the health program planners and the implemented researcher, or the government and the implemented researcher, how to reduce that gap. So Roman, starting with you and anyone, like, it's also to Nepal and China, they feel that there's still gap with the health policy planners and the implementation researcher. How to reduce that gap? Roman?
Yeah, I think, unlike in the poll, China sort of alluded implementation science was introduced by policymakers. In China, it has so far been by and large driven by academia for implementation science. But the policymakers in China traditionally, as I alluded to the beginning, have been very pragmatic, I would say. Many of the Chinese solutions are pragmatic solutions. People have that mentality of get things moving forward no matter what. That momentum of change, reform has been very deep in not only in the general population, but in particular in many of the policymakers' mindset. So, however, having said that, that is not to say there's no gap. There's actually many gaps between policymakers and so this is a thing we are looking at, something we call the policy implementation as well. There are many things we can looking at that. Policy itself can be a problem if we are using the pedals to looking at that. If the policy was not implemented, then policy itself can be a challenge. Then implementation science can be identified. What are the best evidence-based practice which can get that policy into place? And what are the determinants of not using that evidence-based solution to implement that policy? and what are the implementation strategies can facilitate that EBP so that a policy can be implemented. But we can also looking at the policy itself as evidence-based practice. If there is evidence to support one policy has evidence to suggest it can actually bring about a good health outcome, then policy itself become the evidence-based practice. Policy can also become the context where implementation will occur. So they can be either the good policy can be facilitators, bad policy can be barriers to the implementation of a given EBP. But policy can be also implementation strategy, which can be used to overcome some of the policies. As in many low-income countries, global south, many a time the implementation barriers and the facilitators are coming from the outer settings. And in this case, many a time the policy itself is a strong implementation strategy in that sense. So there are multiple ways policy can introduce to the landscape of implementation science. They can be the barriers, they can be facilitators, or they can be the problem itself, or they can be the implementation strategy. In China, all of those things are happening, and it's a long way to go. We can deal with all of them.
Thank you. Archana, Nepal, because then I'll come back to you, Archana.
Yeah. I do agree that there is a big gap between implementation researcher and policymakers and program implementers in context of Nepal, and just in general to build any relationship and to nurture any relationship, we need time, we need effort, and we need like a continuous engagement. So in context of Nepal, we have there are certain steps that government has taken and academia has taken in order to enhance or engage more each other. Usually, like when we think from the brain of a researcher, we usually think that, oh, how do we engage policymakers in our research? But flipping that coin, we might the policymakers also need to think, oh, how do I engage researcher in our programmatic aspects? So we are having those kind of conversation continuously within different levels of government and non-government like programmatic agencies. And as a result of that, I think the two concrete steps are being taken in context of Nepal. One, Ministry of Health and Population is now starting a policy dialogue or implementation dialogue center, so where policymakers, program planners, and implementers would continuously engage. Like we are actually planning to have at least 3 meetings a year where researcher would present and the policymakers would present their like issues and discuss together as a team. And second is now we are continuously engaged in our ongoing programmatic aspects. So traditionally, like researcher would conduct a research and then do a dissemination of the result, which we are continuing. But now the program planners and policymakers are also inviting us, the representatives from academia, while they are doing their strategic planning and they are planning for like a new program on policy. Like for example, in the last 2 weeks, I have received like 5 invitation letter to participate in these kind of dialogues, which is very new for us and very encouraging. And a lot of faculty members from our institution and from other academic institutions are now participating in these kinds of dialogue. We are receiving invitation to go attend their review meetings of program where they are discussing their barriers and why they were not able to achieve certain programmatic indicators. So this has been, I think there are small steps. I know we have a long way to go, but I think this is very encouraging that's happening in Nepal.
That's excellent, the structure step. Yudi.
Yes, this is why from the beginning I mentioned that in Indonesia, we feel that when it comes to implementation science, it's not suffice if we only build the capacity from the academic side. We also need to build the capacity at the program implementation side. So we do both at the same time because that will reduce the gap. And also in many of our programs, training, workshop, we do actually joint capacity building. So in many of our courses, it's not individual based, but it's team based, meaning 3 to 5 people, combinations of researchers and program implementers. So they are together in teams because we need to bring them together from the very beginning. And that's how we design most of our implementation research workshops and training. And also, just recently, also the Ministry of Health is now adopting that approach. So when they have these implementation research projects that they're sponsoring, they invite teams, which are combinations of researchers and program implementers. So that helps somehow to help reducing the gap. Of course, not 100%, but it's a step closer to that. Over back to you, Malabi.
Yeah, because we heard today, like Singapore, South Korea, Indonesia, that many professors academics become the policymakers. My last, the question from the audience about the funding. So that's the funding for implementation research is not much, that not many donors give fund for implementation research. So this like, how can we attract the fund and how can we promote the local funding to create an implemented research ecosystem? Piyusha. The
Okay.
funding, how can we encourage? Because
Yes.
there's funding is not enough for implementation research. Yeah.
Very, 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 very relevant question, Malavika Dev. So definitely we have to do something to move from the donor driven to a locally led IR ecosystem. We have to create this if we want that. So we have various ways to do that. First and foremost, we as an academician, we can be engaged if we engage in the national or subnational priority implementation research priority setting process by the government and the ministry, then definitely we can move from donor driven to locally led IR ecosystem. And secondly, as I said, I mean, if I talk about India's context, so we have Indian Council of Medical Research, that's an apex body for the formulation, coordination, and promotion of biomedical research. And it's one of the oldest medical research body, and they have a specific institute that promote implementation research in non-communicable diseases in NCT. So we have now our MOU, like IHMR University has an MOU with the National Institute of Implementation Research. So in that ways, we mutually, we are preparing the proposals together for implementation research. And definitely we together, I think we can build a system so that we can, steer the research agenda. And also we can engage our decision makers, in this. And second thing, if we create, a pool of trained researcher and embed them within our health system, then definitely we can move, ourselves from the donor driven to the locally led IR ecosystem. And a synergy should be created between the public health professionals and as well as the academicians who are too implementation research focused. So if we, if the public health professionals and the academicians are involved in a implementation research project, I think this thing can be done.
So, like Archana, you bring lot of research grant. I know that. So, how to sensitize other donors, non-traditional donors, to encourage fund for implementation research quickly? Yeah.
Yes, I won't take much time. So I'll just give you an example. So we are doing a lot of foundation grant as well, and almost all of the programmatic grants require monitoring and evaluation. And if we can build in our implementation research questions, so to answer if we build in our M&E system to answer our implementation research question as we go, I think that can be one of the efficient ways of getting things done in implementation research. Because for programmatic purpose, also we would need to document all of the like outputs and then activities and like all of the need to create like logbook and do a lot of documentation, but using that data to answer a specific research question in terms of implementation success or failures can be beneficial and efficient way.
So we should actually promote, I think I was talking last couple of years, that integrating implementation research into the monitoring and evaluation framework. So we have 5 minutes. So I just will give 1 minute to each panelist to have your last thought about how to improve or encourage the collaboration between the Asian universities. Yodi.
Yeah, to improve collaboration with Asian universities, I think this is something which is urgent and critical, because one of the criticism at the moment is that implementation science is heavily dominated by high-income countries for the moment, and so it's not really addressing the need or the relevance or the context of Asia. So it's really so there's a big need for that, and I think we had a good start with Roman in China, in Guangzhou a few weeks ago, and to have that Asian Society for Implementation Science, I think it's a great initiative that will bring together institutions, researchers from across Asia to work together and to collaborate to advance implementation science within the Asian context. Back to you, Malabika.
Roman?
Yeah, I want to second what Yodi said. I think sometimes it's amazing how little we have been working together with our neighbors. We worked with many people coming from afar, but not so much with our neighbors, even within Asia. So I hope this Asian Society for Implementation Science can become a huge booster for regional collaboration. And this model maybe can be replicated in other regions as well.
Piyusha?
I think this IR cross-country IR collaboration can be promoted if we together as an institution, we invest in our mutual capacity building, and we can build partnership with each other in writing, proposals together, conducting implementation research together, co-creating some of the training material together. And we as an institution can plan for joint training programs. We can also, have some co-mentoring or mentoring of the students from other countries, so that they can get different perspective, and also the student exchange should be done, so that the expertise and as well as the benefit, it can flow in the multiple direction.
Archana?
Yeah, so I second everyone. So, and I think in addition to that, specifically in Asia, I think we can also move forward with methodological innovation and implementation science. So, for example, we don't have like tools to measure our fidelity of intervention or acceptability, or we are always like using tools that has been developed in different contexts and in different cultural settings. So bringing like having like chipping on our own experiences and expertise, pushing up like envelope a little bit forward in the methodological aspects, in addition to like training, and then and ASIS is a great innovation, like innovative step and platform. So in addition to that, I think working together and pushing ourselves a little bit forward would be helpful. Yeah.
Okay, so with that positive note, I want to thank all my panelists. Thank you so much. I know that it's the evening, late evening in China. Thank you, Roman, Yodi, Archana, and Piyusha to join the panel. I thank all the participants for their wonderful questions. And thank you, Peter, for co-hosting these two panels. And thank you very much, Keith. Maybe the next CUGH conference we could host in Asia, maybe in 2029 or 2028. Yes. Thank you, everyone. Thank you so much. Thank you for your contribution.